to the Cambodia trip.
Yep.
So we still but we work with Cambodia already, so they should get you a ticket soon.
Okay. No worries. I'm sure all is going to be good. It's going to be great.
Okay, and the van I will for the transportations I will send it to Bass, so she will forward it to you.
Okay, sounds good. I think people are start trickling in.
Yeah.
Okay.
Oh,
We'll give them a couple of minutes and then we'll get started. Justin, good to see you. It's been too long. I hope you're well.
Lovely to see you too. How are things?
I am here with Kim Lu. We're giving the boards. We're in Dallas for the colorectal board exam.
Oh my goodness. How's it going?
So we are, yeah. You're seeing the background of the hotel lobby.
So far, so good for you?
Yes, all great. We made it fine, so we cannot complain. It's way too hot over here. It was like a little bit of a shock exiting the air-conditioned airport, but it was fine.
Good practice for Bangkok.
Yeah, yes. Uh-huh.
Hi, Prof. Good morning.
Good morning. How are you?
Raining every day here.
Raining every day. Oh,
yeah.
okay.
Yeah. So
It will be
anyway,
very green.
you when you come, it should be no rain. Yeah.
No rain. Okay.
So
We can get started. Is
yes,
this an okay?
yes.
Get
Thank you.
started. Okay. So I wanted to say good morning to everyone. We had a little bit of a change in schedule. Meredith, our wound ostomy nurse, who was to speak today, is on medical leave. So we rescheduled it for October 16th. Actually, this was perfect because I really wanted to introduce to all of you a superb young surgeon we have in our department. Dr. Divya Sood, who came to us from University of Chicago. She's a surgical oncologist, and her interests are in oligometastatic colorectal cancer. And now she performs all the HIPEC procedures for us, all the cytoreductions. And I know Dr. Sarinda is visiting us soon, and she'll be spending time with Dr. Sood. Learning about HIPEC, how to set up a new center with HIPEC, and so forth. Divya, thank you so much for being here today. Kim and I together here, we're saying hello and thanking you. And we're looking forward to your talk on HIPEC. And I'm going to mute so I don't disturb here with the background.
Okay, well, yeah, thank you all so much for having me. It is a little bit of a change in the topic, and so hopefully I can still live up to whatever you were hoping to hear about today. Let me share my slides real quick, and then we can get started. Okay, can you see the slides okay? Yeah, okay, great.
Yes.
So yes, thank you for the introduction. I'm going to talk today about sort of the use of this form of a regional therapy of intraperitoneal chemotherapy, typically in conjunction with the cytoreductive surgery, specifically focusing on kind of colorectal and appendiceal cancers. Just as a caveat, this is a little bit of a, surgical focused talk, and I don't want that to bias anybody into thinking that surgery is always the right answer in these cases, in these situations. But we're going to be talking a little bit about indications and then a lot about the technical aspects of the treatment itself. But I just want to make sure there's that caveat that this is not always the right answer. I don't have any relevant disclosures today. In terms of what we'll talk about, a little bit of an overview of peritoneal surface malignancies, but then jump quickly into kind of, like I said, kind of the technical aspects of the cytoreduction and intraperitoneal chemotherapies, the surgery itself, and talk a little bit about kind of candidacy indications, who this is appropriate for, a little bit about kind of the multidisciplinary program, how to take care of these patients, and then if we have time, maybe talk a little bit about some of the emerging or ongoing research and treatments. So peritoneal surface malignancies, it's a very broad term, heterogeneous group of diseases. It's not necessarily something you can really define as one pathophysiologic process. You know, there's primary cancers of the peritoneum, there's secondary cancers that spread to the peritoneum, but you know, oftentimes, depending on the situation, you know, we try to focus on the surgery side anyway, on the patients with these peritoneal malignancies that fall under kind of more of a regional or oligometastatic pathway. So like I said, very broad. There's a very long list of cancers that can either originate in the peritoneum itself, like primary peritoneal cancer or mesothelioma, and then many different cancers, both intraperitoneal as well as extraperitoneal, that can spread to the peritoneum. We're going to focus today, like I said, on kind of colorectal and appendiceal. So a little bit of terminology. So you may hear peritoneal carcinomatosis and you may hear pseudomyxoma peritonei, or PMP. They are often used interchangeably, though they don't mean exactly the same thing. So peritoneal carcinomatosis often looks like this, right? This is what we see. We see kind of flat white lesions studying the peritoneum, both, you may see parietal, you may see it on the viscera itself, but this, this more, those flat white nodules, sometimes there's some serous or thin ascites associated with it. That's typically what we're referring to with peritoneal carcinomatosis. It's pretty broad. It's usually referring to the spread of a cancer from somewhere to the peritoneum, and it's typically arising from a carcinoma. But that carcinoma can be ovarian in origin, gastrointestinal in origin, breast in origin, etc. So it's still fairly broad. Pseudomyxoma peritonei, or PMP, on the other hand, is referring to a syndrome of mucinous ascites. Essentially, it is where the abdomen, the peritoneal cavity, becomes, covered in this mucinous ascites, these mucinous tumors on the parietal or the visceral peritoneum. The overwhelming majority of these syndromes come from an appendiceal primary. They can less commonly come from colon cancer. That's probably the second most common. Can also come from the ovary, from gastric cancer, from pancreas cancer, really any tumor that can be mucinous can technically lead to this syndrome. But like I said, the majority of them are going to be appendiceal. Not all appendiceal tumors result in PMP, but any of them could potentially, so either low-grade or high-grade tumors from the appendix can result in it, but not all of them will. If left untreated, eventually the natural history of PMP is to end up at a malignant bowel obstruction. There is a grading system. There's been a lot of changes in the terminology and the classification of pseudomyxoma, but this is probably currently the most widely used grading system, and it's essentially, low grade is almost always going to be from a very low grade appendiceal tumor. High grade usually indicates that it's coming from an adenocarcinoma of the appendix or somewhere else. And then if it's got signet ring cells, that's usually a very high grade, poorly differentiated tumor that it's arising from. That being said, it's important to note that the PMP and the primary tumor don't always correlate in their pathology or their behavior. So this is an example of what PMP looks like, where you have sort of these large, bulky mucinous tumors in this case that have replaced the omentum. You may have smaller mucinous tumors like this that are sitting on the peritoneum. You may have some mucinous ascites in there as well. So it looks different than those higher grade flat white lesions. So presentation of peritoneal surface malignancies from either colon or appendix, oftentimes it's something incidental. It's found at the time of surgery for something else. You're having an appendectomy, you're having a hernia repair, you're having maybe surgery for your primary tumor, and this is found incidentally at that time. Alternatively, it may be found before surgery from large volume ascites, maybe they're adnexal masses, maybe very symptomatic hernias that lead to imaging. And it can be imaging. So you can have findings like this, right, where you see omental caking up here, where you see large volume ascites, you see a large ovarian mass, et cetera. But oftentimes that's not the case. Oftentimes what we have is a CT scan or a read that looks essentially normal. And then in reality, they go in for surgery for something else, and this kind of disease is found. And so once you do have the diagnosis of peritoneal disease, whether pseudomyxoma or peritoneal carcinomatosis, the workup is fairly straightforward. You get tumor markers to trend over time. If it's colon cancer, you're following CEA the same way that you would in non-peritoneal disease. If it's appendix, usually you're going to get all 4 of these because any of them can be elevated. Not all of them will always be elevated. Genomics, germline testing, it's important to note that appendix cancer is genomically distinct from colon cancer. They oftentimes get kind of lumped together in the peritoneal space as well as in the localized space, but they are genomically distinct cancers, and so that genomic workup is important. Imaging, like we talked about, it's useful to sort of rule out or evaluate extraperitoneal disease. It's not the most useful when it comes to peritoneal disease itself. And very rarely is the peritoneal disease going to be PET avid on a standard FDG PET, and so it's typically not useful again in the staging component of this unless you are looking for extraperitoneal disease. So probably the most critical step in the workup or the staging of peritoneal disease is the laparoscopy. At that laparoscopy, we are there to assess the amount of disease, the type of disease, whether it looks like a more invasive high-grade type of disease or a lower grade or a mucinous type of disease. A lot of that you get just from the visual aspect of your assessment. And then the location of it is very important as well. And so we use the PCI, or the Peritoneal Cancer Index, as sort of a way to attempt to create an objective quantification of something that is ultimately a subjective assessment. But we divide the peritoneal cavity into 13 regions. So 9 of them are sort of quadrants on a tic-tac-toe board. And then the last 4 are segments of the small intestine, the jejunum and ileum. And each of those gets a score from 0 to 3, depending on how much disease we see. And that gets totaled to a score between 0 and 39. And we'll talk a little bit about what to do with that number later on. But it's particularly important because those factors really impact the outcome, your ability to achieve a complete cytoreduction, and then ultimately, the patient's outcome or likelihood of benefiting from the surgery. This is one place where that number comes into play. So this is a score that was developed specific to peritoneal metastases from colorectal cancer, the peritoneal surface disease severity score. It takes into account 3 separate categories. One is clinical symptoms, one is the extent of carcinomatosis, or that PCI score, and then the primary tumor histopathology. And based on those findings and the score that you get from there, there's sort of a peritoneal surface disease staging separate from, the AJCC staging or TNM staging. And this is then can be kind of correlated to expected outcomes after a cytoreduction versus with systemic therapy or anything else. And so you can see there are a couple of things that really make you jump up. So if you have poorly differentiated or signet ring cells, you're already up here at a stage 3 without even taking into account anything else. Similarly, the extent of carcinomatosis above 20, again, you're jumping up pretty high. You add in even just a little bit of symptoms associated with that. And again, you're already at stage 3. And so this is just a little bit of a way to help quantify or categorize in your head, is this patient really going to benefit from this operation? This is not a hard stop to say that anybody who's up here at stage 4, you absolutely can't do it, or anybody down here at stage 1 absolutely should have it. It just helps in sort of the risk benefit analysis. So we'll talk a little bit about, treatment options for these higher grade tumors, those that are, either colorectal cancer or the higher grade appendix cancers, moderately or poorly differentiated, whether mucinous or non-mucinous. We typically go for the multimodal approach, meaning systemic therapy combined with surgery. I'll talk about that a little bit more later and some newer data that's come out in this space, but the multimodal approach really remains kind of the standard approach here. For the lower grade tumors, these low grade appendiceal tumors, including some of the well-differentiated appendix tumors, surgery is really the best treatment, the only known effective treatment to treat those. And so we approach them a little bit differently in terms of the indications. So let's talk about the surgery itself. The most common surgery that you're going to hear about in this space when approaching peritoneal disease is cytoreductive surgery, or CRS, and hyperthermic intraperitoneal chemotherapy, or HIPEC. This is a little bit of a schema sort of representing what the patient may end up experiencing. It doesn't look exactly like this in reality, but it's kind of a schema for it. So it's a combined approach using surgery to first remove all of the visible disease from the abdomen. That's the cytoreductive portion. And then the second part of it is to infuse heated liquid form chemotherapy into the peritoneal cavity with the goal of sort of eradicating any residual microscopic tumor cells. There's really 2 major categories in terms of your intent. There's the curative intent and the palliative intent approach for this operation. Curative intent is the cytoreduction. That means that we are there to remove all gross disease. The palliative intent more often is, we're there just with the goal to palliate symptoms. And so you may just be debulking. You're not necessarily able to remove everything. And so your goal is just to debulk as much as possible. Or you may be going in truly just to palliate one specific symptom because you can't get everything else out. This is more often than not something you're going to do in the setting of Lamin, the really low grade appendiceal tumors. For the higher grade tumors, there's just not as much benefit to this. So the surgery itself, cytoreductive surgery, is a really generic term, right? It can include almost anything. So somebody who has had a cytoreduction before, you really have no idea what that means. This is kind of a laundry list of the kinds of operations that could be included in their cytoreductive surgery. The lower grade their tumor, the more things may be included. We get more selective with the higher grade, or the more aggressive their histopathology is, we get more selective about it. So they're more likely to have kind of a less extensive cytoreduction. But for the low grade tumors, it could encompass multivisceral resections. These are a couple examples of what the surgery itself looks like. So for these peritonectomies that I listed here, peritonectomies off the diaphragms, from the anterolateral abdominal wall, down in the pelvis, retroperitoneal, porta hepatis, IVC bursa, et cetera. It's pretty much anywhere that you can find the peritoneum, you can perform a peritonectomy there. with the exception of a few of the solid organs. And so this is an example of kind of what it looks like. Typically when I approach this, when I know ahead of time that I'm going to be doing, extensive parietal peritonectomies, I will open their midline only through the fascia, but then keep the peritoneum intact, and then dissect this down in an extraperitoneal fashion. And so my hand here is kind of holding down on the peritoneal sac with the posterior sheath up above and using the cautery to kind of separate these planes. And you continue this dissection until you get to a place like this, where you've separated this peritoneum circumferentially from the diaphragms above all the way down to the psoas laterally and down off the bladder and the peritoneum down this way. Sometimes you end up taking the umbilicus with it, like in this case, where there's clearly tumor within the umbilical stalk. This is another example of what that looks like when you've kind of dissected this peritoneal sac. You can see the iliacs and you'll have the ureters lateralized, etc. So you get a fairly good complete parietal peritonectomy when you do it this way. Once you've opened the peritoneum, so you've taken it off kind of the parietal side, then you open that peritoneum and continue that. And this is an example of kind of showing what it looks like after we've completed that right diaphragm peritonectomy. The diaphragm muscle is all behind this retractor. We've mobilized the right lobe of the liver, which is rotated medially here. And you can see behind here the kidney, adrenal gland, IVC, etc. So all the peritoneum is off this retrohepatic space as well. A couple more examples of what the surgery may look like or what you may find. So this is the appendix. And what you see is actually just a very small mucinous tumor at the distal end of this appendix. And this is actually a large adnexal mass that is the result of this tiny tumor having spread. And some of the mucinous ascites, again, that you may find at surgery, and a couple more examples. So sometimes the surgery looks like this, where you're just there to quite literally scoop out mucin from inside their abdomen. Or maybe you're just taking out a large bulky omentum, and maybe underneath this, there may not be any other disease. So it can be really variable. Goals of the cytoreduction. This is another thing that actually is histology specific. So say outside of the GI space in ovarian cancer, there's actually a tolerance for more residual disease. And part of that is related to the efficacy of their systemic treatments relative to the efficacy of the GI, the response rate and efficacy in the GI space. And so this is another thing that's a little bit, again, disease specific, but typically your goal is going to be to get to a complete cytoreduction, which is usually defined as a CC0 or a CC1, so having less than 2.5 millimeter thickness of disease left at the end of the operation before you perfuse with the chemotherapy. So this completeness of cytoreduction score, or CC score, is another way that we use to kind of define the completeness of the surgery that we performed and whether it's really a cytoreduction or more of a debulking. So after the cytoreduction is typically when we approach the intraperitoneal chemotherapy part of this. I just put this up here as a note to say that HIPEC is really only one form of intraperitoneal chemotherapy. There are a lot of other forms in which you can do it, but HIPEC is the one that is most commonly used. Several of these other ones are some of them are used not in conjunction with surgery or cytoreduction, like the pressurized aerosolized chemotherapy or the normothermic, which is performed sort of iterative as a port-based treatment. And so there are other forms, but we're going to talk mostly about HIPEC today. This is kind of what it looks like. You have a temporary abdominal closure at the end of your cytoreduction, and you've placed inflow and outflow catheters here that allow the chemotherapy to circulate through the abdomen. Like I said, typically a closed fashion, so you have this temporary abdominal closure. And people do that a little bit differently, but it's typically done in a closed fashion. There does also exist an open Coliseum technique, which has mostly fallen out of favor due to the exposure risk associated with that. But there are some places where it's still done. And with that inflow and outflow catheter going through there, the setup is usually that there's a hyperthermic pump, so a pump that has an external heater associated with it that heats and circulates the chemotherapy in a perfusate that then perfuses and circulates through the abdomen. The duration of the chemotherapy treatment is between 30 and 120 minutes. Most commonly for appendix and colorectal, we're using a 90-minute perfusion. During this time, we do really closely monitor the patient's core temperature. The perfusate is heated up to about 43.5 degrees Celsius, and so it ends up settling out around 41 to 42 degrees when it's coming back out of their abdomen. Their core temperature does usually rise, but we tolerate a little bit of systemic hyperthermia before we start actively cooling. But we do make sure to keep them, under 39.5, ideally under 39. There's also some variation in terms of the approach. Some people have heard of the term shake and bake, which is essentially sort of a colloquial term referring to the process of agitating the patient's abdomen while the chemotherapy is perfusing. It's not, necessary to do that. And in my practice, we don't do that. We just change the bed position every 15 minutes or so and allow it to do that, because there's a high enough flow rate in the perfusion itself at a liter a minute that you don't necessarily need any additional agitation. But you may see that and hear that a lot. So why intraperitoneal chemotherapy? The rationale behind it is that it's a regional therapy. It's applied directly to the site where the disease is. And therefore you can, give a much higher dose of the chemotherapy than you can give systemically and have lower toxicity associated with it. There's also some hypotheses that there is less penetration of systemic chemotherapy to the peritoneum itself. And there's sort of mixed data on how true that is, but that is another sort of hypothesis that led to the development of HIPEC. Why the hyperthermia? There's a few reasons again behind that. One is the heat itself has been found to have cytotoxic capabilities. But beyond that, the bigger reason really is that the heat has been shown to increase the sensitivity to the chemotherapy and increases the depth of penetration of the chemotherapy. There's also some research going on about its ability to sort of act as an immune modulator, but that's still somewhat under investigation. The chemotherapy agent, the selection, has varied to some degree over time that we've done this operation. But the principles behind the selection of the agent are you want a large enough molecule that's less likely to kind of cross the peritoneal blood barrier. So something that's less likely to have systemic absorption, because the whole goal of this is to keep it as a regional therapy rather than a systemic therapy. Something that, like I mentioned, will synergize with the heat. That obviously is effective against the cancer that you are treating. Most commonly for both colon and appendix, we're using mitomycin C. There are some centers that still use platinum-based chemotherapy for HIPEC for colon and appendix, but it's again fallen out of favor quite a bit. And then there are several others that are used in other histologies as well. So a little bit of the kind of recovery or the statistics in the literature, what's published out there is that the median operative time is somewhere in 8 to 12 hours. It's extremely variable. It's rare that it's less than 5 or 6 hours, but it's not uncommon for it to be 12 or 15 or 18 hours. But 8 to 12 is probably where the median is. It's really variable dependent on the patient's biology, the extent of disease, et cetera. Morbidity, again, what's published is really variable, 15 to 75%. It's like I said, very, very variable. Mortality is published in the 0 to 15% rate. When you look at high volume centers, that comes down to closer to 1 to 2%. And that's certainly something that has decreased over time as we've learned more about how to do this operation safely. Length of stay, what's published is around 7 to 14 days, and recovery, ongoing recovery beyond that, several months. You know, we talked about high volume centers and the importance of that. I think that it's important to mention that these are big operations in patients who often are coming in with a significant amount of deconditioning. They are nutritionally behind. They are sort of starting out at that place. Many of them have been on systemic therapy for a long time already. And some of them may have, you know, partial bowel obstructions, et cetera. There's a lot that they're already coming in sort of at a deficit. And so having a sort of prehabilitation program in place to get them up to speed and get them optimized before surgery is super important, because all of these things that they can come in with, they sort of get worsened by the surgery, by the treatment itself. And so you want to optimize them as much as possible beforehand, and then continue those same practices post-operatively very early on. And so our team here really does include a pretty wide-ranging multidisciplinary team, all with the goal of sort of, like I said, optimizing the patients, improving their outcomes as much as possible so that this can be an effective treatment and not cause more harm than good for them. And so with that, this is again just sort of a little bit of data suggesting that when you have a higher volume center, when you have a robust program and multidisciplinary systems in place, then you can see, you know, improvement in sorry, this should actually be updated. You know, to have low mortality rates, low readmission rates, low ICU admission, length of stay of, you know, less than a week. All of these things get better as you build those support networks for your program. So again, most of the time what we see is that most of the patients are off pain medication within about a week of discharge after the surgery. The things that linger the longest, the things that take the longest to come back are energy levels and appetite. And that's really, really important to pay attention to, because those two things will play off of each other and sort of spiral into failure to thrive. And so that's probably one of the biggest risk factors or complications after the surgery. It's just that potential to fall into a failure to thrive cycle. And so that's where those additional supports and other team members come into play to try to mitigate that. But, you know, for the higher grade disease, for patients who need to get onto systemic therapy, most of them are able to get back onto it within about 4 to 6 weeks after surgery. And then they continue on surveillance, usually with imaging and tumor markers after that. When it comes to oncologic outcomes, you know, for colon cancer, we're seeing median survival after a complete cytoreduction and HIPEC somewhere in the 40 to 60 months range. 10-year survival of 16%, but if they have a PCI less than 10, so a low burden of disease, that increases to 40% 10-year survival, which for stage 4 colon cancer is very good. For the low-grade appendix tumors, the ones where we're not treating with systemic therapy and really their only known effective treatment is this surgery, is either cytoreduction or debulking. We're still seeing overall survival, you know, in the multiple decades range. And so there are, of course, patients where that's not true, and they unfortunately have usually the thing that ultimately ends up killing them is a bowel obstruction. But if we're able to get them a good cytoreduction, or at least give them enough of a debulking that we can clear their GI tract, they'll see years, 10 to 20 years or more of survival. Appendiceal adenocarcinoma, so the higher grade cancers, is different and is a little bit closer to what we see with colon cancer, but it's really variable. So if you have somebody with a moderately differentiated mucinous adenocarcinoma with low burden disease, they may end up having a survival similar to a patient with Lamin, with a low grade appendix tumor. Whereas if you have somebody with signet ring cell, poorly differentiated, and high burden disease, their survival may be more akin to somebody with pancreas cancer, with metastatic pancreas cancer. And so the appendiceal cancers are pretty variable. The other part of this from the survivorship standpoint is just, you know, when it comes to this operation, we did look into whether or not ultimately patients were glad that they proceeded with this operation or not, because it's so big. There's definitely a concern that patients may have regret. You know, ultimately, the overwhelming majority of patients, you know, close to 85% of them ultimately said that it was the right decision for them, that they did not regret having the operation. The factors that were associated with decision regret were those that I have listed here. So patients who ended up with an ostomy as part of their operation, patients who were having a recurrent or a repeat cytoreduction, so if they've had it multiple times, anybody who had a greater than 30-day hospital stay, which correlates with those who had a major complication, and interestingly, those who had a lower income, that's where most of the decision regret was associated with those factors. But the majority, again, like I said, ultimately did not have any regret. So I do want to talk a little bit about candidacy for the operation. We've kind of touched on it a little bit throughout, but we'll try to summarize it a little bit. So evaluating candidates for cytoreduction and HIPEC, there are several things that factor into it. The type of tumor, like I said, the site of origin, the histopathology, the extent of the disease. So like the PCI that we talked about, limited or no extraperitoneal disease. So do they have liver metastases? Do they have lung metastases? The findings on imaging and laparoscopy and whether or not you think it's possible to perform a complete cytoreduction. For patients who are getting systemic therapy for the higher grade tumors, then whether or not they've responded to systemic therapy is going to factor into it. And ultimately, because of all the, you know, like I mentioned, the impact on quality of life and the kind of the strain that this operation can cause, their ability to tolerate it. So all of these things kind of get summarized into probably 3 factors. One is host factors. So the patient, whether or not they can tolerate the surgery, their performance status, their comorbidities, and that includes their nutritional status, their mental health, all of that, whether they can tolerate the surgery itself. Technical factors, so that's the PCI, the burden of disease, the extraperitoneal disease. Is it technically resectable? Is it something that we can actually remove? And then the third one is the disease factors, and that's the tumor biology, which of course is often the hardest one to define. And it's the one that is also the hardest for patients to grasp, I think, when number 1 and number 2 are okay, meaning they can tolerate a surgery and we can remove it. If we say that we shouldn't remove it because of the disease biology, that's really hard for them to grasp. But oftentimes that is what we have to say. And so we don't know everything that factors into the tumor biology and into this component, but certainly the histology, the genomics, the response to treatment, multivisceral disease, those kinds of things all play a role. A little bit more specific. So for appendix tumors, like I mentioned, that PCI plays a role in sort of who's a candidate for this. So for the lower grade appendix tumors, there's no true maximum PCI. So there's not a cutoff where we say you're above this and therefore you cannot, you know, be a candidate for surgery. It comes down to more whether or not you are able to offer them a complete cytoreduction or you're offering them more of a debulking. But because there are no other known effective treatments for these patients, cytoreduction and HIPEC is really what you're going to offer. For the moderately or poorly differentiated adenocarcinomas, mucinous or non-mucinous, it does, it sort of parallels our management or our thought related to colon cancer. So the PCI cutoff is around 20, 19 to 20. And the reason that I say cutoff in quotation marks is because it's not a hard stop. It's not that if you have a PCI of 21, you're absolutely not a candidate. And it also doesn't mean that if you have a PCI of 3, you are definitely a candidate. The other factors play into it as well. You know, if you have a PCI of 3, but it's all wrapped around the porta hepatis, you're still not going to be a candidate for the operation. And on the other hand, if you have a PCI of 21 or 22, but you have had stable disease for 2 years and the histology is really good and you're in excellent shape and it's all parietal peritoneal disease and very little visceral involvement, then maybe you're still going to be a candidate for this. And so it's, again, it serves as a guide, but not by any means a hard cutoff. The bigger thing really is, you know, if any of those other factors don't line up, then we certainly shift away from surgery and more towards systemic chemotherapy. This is a little bit about the sort of appendix cancer outcomes that have been published after cytoreduction and HIPEC. This is one of the challenges that we have in this field, is that because of the rarity of appendix cancer, you end up with studies like this where a lot of different histologies get lumped in together. And so this is a study that's fairly representative of a lot of the appendix cancer literature, which is that it encompasses low grade, high grade, very high grade appendix cancers, mucinous, non-mucinous, et cetera, into one. And so this is the data that we have, but it's not the most informative. This is saying that, you know, after cytoreduction and HIPEC for pseudomyxoma from appendiceal origin, again, low grade or high grade disease, we're seeing median overall survival of 16 years, median progression-free survival of 8 years. And the things that were associated with a worse overall survival were a higher PCI, higher grade, and previous surgery. Previous debulking or cytoreduction associated, you know, for the same diagnosis. Systemic therapy. So for those patients with appendix cancer who are who have higher grade disease, like I said, multimodal treatment is usually the approach. So a combination of surgery and systemic treatment. One of the challenges is that there is not always a huge peritoneal response rate. More often what we will see is disease control. And so one of the things that's that you have to sort of moderate patients' expectations is that if you tell them you're not a candidate right now, but maybe with some systemic treatment, you'll become a candidate, there's sort of a limited number of patients where that's going to be true. More likely than not, it's going to be a matter of disease control rather than truly shrinking their disease to the point that they become cytoreducible. So the goals of systemic therapy are more often than not about preventing extraperitoneal dissemination, assessing their biology. So are they going to respond? Are they going to have that disease control? But less often truly conversion to resectability. Sometimes we do. Again, appendix cancer is not the same as colon cancer. And yet that is where most of our systemic therapy regimens come from, simply because of the rarity of appendix cancer. We don't have good data to say that we should be doing anything different, or necessarily to say what we should be doing instead. So it is still a 5-FU backbone with doublet or triplet regimen. Very rare to see high tumor mutation burden or high PD-L1 or anything to suggest that these would be immunotherapy responsive. I won't go through all of this right now. I just want to put a plug out there that this is useful information. So since for appendix cancer, as well as for peritoneal surface malignancy from colon cancer, there isn't really good guidelines in the NCCN guidelines or any of the other major pathways. the field sort of took it upon themselves to create these. They were first created in 2018 and they were updated. It says 2023 because that's when the update was started, but they were actually just published earlier this year in June. And so they are all published and available now for these updated PSM consensus guidelines. And there are pathways available that kind of go through appendiceal adenocarcinoma, as well as the low-grade appendix tumors, both localized and peritoneal disease for all of these. And so just a plug for that useful reference. Colorectal, so again, back to that PCI, similar to the high-grade appendix cancers, ideally you want a PCI less than 19 or 20, but again, not a strict cutoff. The lower we see it, the better the outcomes overall. Again, multimodal approach. We talked a little bit about the survival that we see with this already, kind of median survival, 40 to 60 months after a complete cytoreduction in HIPEC. Notably, a incomplete cytoreduction for colon cancer is not likely to improve their outcomes. So this is a trial that you may have heard a lot of. This is the one that is most often cited in reference to the use of HIPEC for colon cancer, the PRODIGE-7 trial. It was published several years ago now at this point, and it was a randomized trial comparing cytoreduction and HIPEC to cytoreduction alone. All patients received systemic chemotherapy either before or after, and it was powered specifically to look at overall survival. The ultimate outcome was that there was no significant difference in the overall survival between the two groups, so either cytoreduction alone or cytoreduction plus HIPEC. Notably, despite that finding that was in this larger randomized trial, it hasn't really changed practice. So most people, most surgeons are still performing HIPEC for colon cancer. Some are slightly more selective about it, but very few people have truly given it up altogether. The main reason for that is because the HIPEC regimen that was used in this trial was oxaliplatin for 30 minutes. And that has actually, by the time this was published, that regimen had already been shown on multiple different other studies to not be effective. And when compared to what is used more often today, mitomycin C, there have been several studies that have come out since then saying that mitomycin C is effective and makes a difference in a few different settings. And so the outcome of this trial essentially led the study group in France to switch to using mitomycin C instead of stopping using HIPEC. And so it's sort of similar to, if you have a systemic chemotherapy trial for stage 4 colon cancer that is, doesn't show an improvement, we don't usually say that chemotherapy is not effective for metastatic colon cancer. We say that that particular regimen may not have been effective. And so that's essentially the outcome from this one, is that oxaliplatin for 30 minutes is not effective. But there are a lot of other things that are coming down the pipeline that we are looking at as sort of alternatives or in addition to HIPEC. And so one of them is PIPAC. It's another form of intraperitoneal chemotherapy. This one is pressurized aerosolized chemotherapy. This is the largest trial that's being done right now, the IMPACT trial, and it's specifically for patients with higher grade cancers, so not for Lamin. It's not specific to colon cancer, but colon is currently the largest cohort that's on this trial. So far, we've just seen the early phase data, but there is sort of promising results. In addition, PIPAC is used much more widely in Europe right now than it is in the US. And again, we're seeing good data coming out of Europe related to this. And so this is sort of a promising thing in the pipeline right now. Regarding systemic therapy for colon cancer with peritoneal metastases, this was sort of a highly anticipated trial that they just put out, kind of recently put out some data from it. And this was comparing the use of preoperative chemotherapy plus cytoreduction and HIPEC to the use of just cytoreduction HIPEC alone without systemic therapy. And the short answer is that the most recent data that was put out demonstrates no significant difference in overall survival, but an improvement in progression-free survival with the systemic chemotherapy arm. In talking with my colleagues across the country thus far, again, nobody has really changed practice based on this. Nobody has stopped recommending systemic therapy as part of the treatment for patients who are undergoing cytoreduction and HIPEC for colon cancer. The main reason being that oftentimes with peritoneal disease, progression-free survival is still a very significant endpoint, is still something that matters a lot, since the both from a quality of life standpoint and from a survival standpoint, an overall survival or mortality standpoint, the bowel obstruction is the thing that can be the biggest problem. And so maintaining some degree of peritoneal progression-free survival is still a really valid endpoint, even if overall survival is not different. And so right now, this has not changed practice yet. I don't think that it will. I could talk a little bit about some of the sort of emerging therapies. Oh, this is just one I was going to mention, is that, again, because there is some sort of mixed understanding of what is truly going to benefit or what is truly beneficial in terms of systemic therapy, there are a lot of other sort of ongoing trials for colorectal cancer as well, including looking at immunotherapy. You know, like I mentioned, there's usually not a lot of immune signal here in the peritoneal disease, but there's still kind of a smaller subset that we're looking at where it may be beneficial, and so potentially helpful. And then the last thing I'll talk about is the HIPEC T4 trial, which was published about a year or two ago now, and this was looking at patients with T4 colon cancers, so locally advanced colon cancer, who underwent surgery with essentially adjuvant HIPEC with mitomycin C, and then systemic therapy versus surgery and systemic therapy alone. Interestingly, they had a 3-year local regional recurrence control rate of 98% compared to 88% in with the higher rate being in the intervention arm with HIPEC. This is another one in which we haven't yet started doing this routinely. I think that it's still too early to really say how effective this is going to be and how big of a difference this is going to make. And so it hasn't changed practice yet, but I think it's just interesting to see that there are, potentially other interventions here. One of the things that is of note is that there's some research out there that's showing that, when you look at the peritoneal metastases from colon cancer, when it's still microscopic metastases, there actually is a stronger signal there for response to the peritoneal to the HIPEC, sorry, when it's still microscopic. When it's gross disease, there's much less response. And so this is perhaps picking up on that signal, saying that when we do it early, we're going to have a better response to it, et cetera. But I think this was a small study, and I think there's still more to be investigated here. This is again just demonstrating that we have colon cancer pathways for both synchronous and metachronous peritoneal disease in the updated consensus guidelines. And I'm going to skip over this for right now and just jump to the end and see if there are questions. So, final thoughts are just that peritoneal surface malignancies, it's a pretty broad disease group, so it's hard to cover everything in one talk, but the main takeaway that I want to leave you with is that cytoreduction and intraperitoneal chemotherapy can be really effective in a selective cohort. So in the patients where they meet all of the other criteria, it can be really effective in that group. But they're big surgeries in patients who have a lot of risk for complication. And so having kind of a comprehensive multidisciplinary team is really important. And then there's a lot of exciting things coming down the pipeline. So we'll see what happens next. I will stop there.
Thank you, Divya. This was outstanding. I do have a couple of questions for you, but I want to see if our colleagues from Thailand have questions first. Oh, actually, in the chat, there is one.
Like ovarian gastric.
Can intraperitoneal chemotherapy be applied to other organ carcinomas?
Yeah, so is that referring to like outside of colon or appendix?
Like ovarian or gastric. Have you seen that successful in those?
Yeah, yeah, absolutely. You know, so outside of colon and appendix, I personally use it often for peritoneal mesothelioma. I use it, you know, again, fairly often for ovarian. The space where it's most useful and where the data is most supportive of it for ovarian is specifically in high-grade serous ovarian carcinoma. In the setting where the patient is anticipated to need neoadjuvant systemic chemotherapy and then has a plan for an interval cytoreduction. So neoadjuvant chemo, interval cytoreduction with HIPEC, that's where we have the most robust data to support its use for ovarian, followed usually by additional systemic chemotherapy after that. There's some, you know, in a more rare subset of mucinous ovarian cancer, there is some potential for it there, and then it's more extrapolating actually from some of the mucinous GI cancers that we're extrapolating from that data. And then for gastric cancer, yes, again, I do it very selectively. The reason for that is that the data is still somewhat mixed as to how effective it is. And I think the biggest reason for that is because gastric cancer has such a different biology than a lot of the other ones. It falls into a much higher grade, more aggressive, much more systemic, and much less regional cancer. And so if you're going to apply a regional therapy to it, it's got to be somebody where they've really proven that biology that they're going to benefit from it. That being said, there are some other kind of exciting things that we're looking at in gastric cancer using more of a either iterative laparoscopic approach, so without the cytoreduction, but just doing iterative laparoscopic HIPEC in conjunction with their systemic, so they get kind of a systemic and a regional approach to it, or also, like I mentioned, NIPEC, which is that port-based chemotherapy, so getting it not even needing surgery for it, but getting outpatient cycles of intraperitoneal chemotherapy.
Thank you. I think we can have one last question before the time's up. Ajahn Ton or anyone have a question for her? Ajahn Vinita, anything?
What about pancreatic cancer? Is there any evidence that HIPEC might be useful for like pancreatic peritoneal metastases?
Yeah, it's a good question. So the short answer is no. The short answer is that pancreas cancer, there's no true data to support it. That being said, I have, you know, anecdotal evidence in like I said, really somebody who has truly proven the test of biology ahead of time. And so complete outlier case. I did this in fellowship where we had a patient who had, you know, essentially years, I think it was 4 years of stable disease, of kind of a single site of peritoneal disease metastatic from his pancreas cancer, and had 4 years of no recurrence or progression, including time off of systemic chemotherapy. And kind of as an offshoot, we took him and removed his primary tumor, removed that area where there had been some peritoneal disease seen that wasn't there anymore, and performed HIPEC as well. Did a combination of mitomycin C and a platinum agent, and he remained disease-free until the last time I checked, which was last year. But so, you know, it had been about 3.5 years at that point, but that's by no means something that's clearly somebody who had a pancreatic cancer disease biology that was very, very atypical and different from the norm. And so the short answer is that it's not something that there's any real data to support.
Thank you very much. I think the time is up, and we very much thankful for Dr. Sood for the very advanced talk today. It fits very well with the context here. Thank you very much for sharing with us.
Yeah, thank you so much for having me. And feel free, you know, if there's any questions or anybody wants to talk about it more, feel free to reach out. I'm happy to chat about it anytime.
Have a
Cynthia,
good
thank
day.
you so much.
Thank you. Bye-bye.
Good to see everyone. Great talk. Thank you.